Good morning, anyone. We'll just jump right into the case. I'm Jenny. I have no financial disclosures. Jumping straight in, we have a 22-month-old female who presents with a pigmented lesion on the right eye that was noted at birth by the mom. There's been no problems with vision, no history of trauma, and she's had pretty normal development. She was born at full term, C-section. Notably, the mom is a Fragile X carrier, doesn't have Fragile X, but no medications, and an otherwise unremarkable social history. Can someone describe this for me?
How about Nemo?
It's a 22-month-old female presenting for a lesion on the eye. The lids and lashes look within normal limits, no congenital lid nominally seen. There's the conjunctiva is white and quiet, no injections. The cornea appears clear without haze. The iris is generally blue color. Inferior temporal, there's looks to be about a 2 millimeter hyperpigmented lesion around the angle.
Perfect. So yeah, it's a fairly small pigmented lesion, discrete, maybe a little cystic appearing at around 7 o'clock near the angle, kind of abutting the iris. So what's your differential for this iris lesion?
So in a young patient, it could be congenital nevus. Around 2 years old, you'd be worried about something like xanthogranuloma or other malignancies. It could be cyst.
Yeah, that's fantastic. That's a great list. That's everything on there. So given that cystic appearance, I have stromal cysts and pigmented epithelial cysts up top, and could be, you're right, xanthomatous. We're thinking about JXG. Lish nodule is possible, but a little bit less likely in this child. Nevus, absolutely. And you're right, malignancy is on the list as well. A little bit less likely in her. Parasitic, unlikely given the unremarkable social history. So that's great. And so the child underwent exam under anesthesia every 6 months since she presented here, from 22 months onwards until she was 4 years of age. Her IOPs always fluctuated between 15 and 19, but fairly normal. But over the years, this lesion has just slowly increased in size. So we fast forward to April of 2016. She's 4 years old now, and she presents with headache and right eye pain. Her vision's 20/25 in both eyes, not bad, no APD, but her pressure is 67 in the right eye, 22 in the left, so she was started on dorzolamide timolol in the right eye and taken for an urgent EUA. So even under deep sedation on drops, her IOP is still significantly elevated, 44, 39, 37, normal in the left eye. You could see here on gonioscopy that it's open. You catch kind of the edge. There you go. Catch the edge of the lesion there. We'll show you on the next slide. And you could see this is a significantly larger lesion than the one that I showed you initially. And on the UBM, you can actually see that there's some opacities just floating around in the AC. It's possible that the cyst appears to have ruptured. You could see the wall of it right here. What's not in dispute is there is glaucomatous damage to this eye. You could see initially at her first EUA, you have a very nice nerve. And then on your right here, there is more cupping than previously noted at 4 years and 9 months. So what to do next? So in summary, this is a secondary open-angle glaucoma, probably from a ruptured cyst. These are highly inflammatory. So is it inflammatory, or is there some component of trabecular metaplasia? Given that it has open angle, is angle surgery a possibility, or are we thinking about tube shunt or trabeculectomy? So without kind of jumping, I'll just show you what was done. Let's see if it plays. The first part goes fast, so I'm just going to tell you. You'll see that a 25 gauge needle was inserted and they attempted to aspirate, but nothing came out. So I'm going to start playing that. And that part goes fairly quickly, so you might just miss it. but you could see here, just nothing. You don't even see aqueous refluxing out. The decision was made to do a sector iridectomy, so a broad-based scleral flap was made. So the importance of removing this cyst is that the entire wall of the cyst has to be removed, or else there will be recurrence. So you could see here, they're also, in just a second, you'll see that also taking care to keep the pupillary margin in this patient, but excising the entirety of the iris that has the cyst involvement. So you can see here, it doesn't cut straight into the pupil, it kind of goes around there. And in the next second, as you enter the AC, this gelatinous material just pops right out. So that's part of the reason why when you aspirated, there was nothing that came out. This was sent to pathology. The iris was subsequently removed and the eye is closed. And you'll see in just a minute there, kind of what's remains. You can see there's still, my mouse works here. You can see the pupil right there, but a significant portion of the iris was removed, approximately 1/3 or maybe a little bit more, and it's side L negative. So we're gonna move on. So it was none of the things that I showed you on the slide before. So on pathology, looking at the iris, there's a thin layer of goblet cells. Just you could see right, actually I have an arrow. Right, you could see these goblet cells there. And that was confirmed with the mucicarmine stain, which stains mucin red, so it's confirmatory that these are indeed goblet cells. The AC material, that gelatinous thing that popped out, was mucoid material with some macrophages within it. So what is this? So it's called mucogenic glaucoma. It's a type of secondary open-angle glaucoma that's caused by mucin occluding the trabecular meshwork and thus increasing the IOP. So a little bit different from other causes of glaucoma from iris cysts, a lot of which are plateau or angle closure. So, but before you start making this diagnosis everywhere, there's only been 5 cases reported, and that's including this one. And this is actually the first pediatric case that's been reported. So we're looking at the other 4. The takeaway, excuse me, the takeaway message is that it's split between male and female, and it could actually be from a primary cyst, likely in our child, or a secondary implantation cyst, which unsurprisingly arise from trauma. And you can see the range, it was first described in 78, and just very, very, very rare occurrence, though it could be underreported. We're going to talk about the first one that's a little different. And the reason why is that this case included, and the other 3 that's down here, all had goblet cells lining the epithelium of the cyst, but this one did not. So they did an interesting immunohistochemical study on this patient. So kind of, I'll go over the stains that they used, but I'll cover it again once we show the slides. They looked at secretory mucin, which is mucin that is produced by the goblet cells. So, and also they looked at something called membrane-bound mucin, and the source is epithelial cells. That's the mucin is shed from the epithelial cells. Also looking at the CK19 corneal conjunctival epithelial, which is a corneal conjunctival epithelial marker. So what all that means in context is the next slide. When you look at the H&E stain, yeah, you don't see any of the goblet cells. So, but then if you're staying with CK19, which is a conjunctival corneal marker, you could see that it lights up. And so indicating that this is of conjunctival corneal origin. So if you look at C down here, now they're looking at secretory mucins, MUC5AC. If you looked at our patient, that would have stained positive, but this one did not. And then now, lastly, you're looking at the last slide, MUC1, which looks at membrane-bound mucin, so shed from the epithelium. And this one actually stains. So it's a membrane-bound mucin, so it's a little different. There's no goblet cells, so that's what makes this one slightly interesting. A little bit more about the history of this patient. This is a 56 or 58-year-old Japanese man. This case reported in Japan. But when he was 10 years old, he had a penetrating injury to the eye from a nail. And the thought is that he actually developed a secondary cyst, and very, very slowly the mucin gathered over the 40 years, and that's how he developed mucogenic glaucoma. So again, very rare, but interesting and different from the other cases. So we're going to go back to our patient who has done very well, 2030, IOP is 19 on no medications. So, and a little bit more history from the mother shows that she's had amniocentesis at around 17 to 20 weeks, ultrasound guided. Is this relevant at all in our case? Maybe yes, maybe no. Because if you look at the role of amniocentesis in formation of iris cysts, there are some case reports, but these are always very hard to prove. In this particular case, they found a cyst wall that's adherent to the Descemet's membrane, and also they found cells, epithelium from the conjunctiva within these cysts. And the smoking gun is a perforating limbal scar from this enucleated eye, from these two enucleated eyes. So, are they related? They can be, but unless you have pathology and you have this, it's very hard to prove. Certainly it can cause trauma as well. And again, this is something that's hard to prove. This is a short case series of 4 cases where there was 3 anterior segment and 1 posterior segment rupture, all of which had some kind of an entry wound that was identifiable, noted at birth, and with no other history of trauma that could possibly explain this. So there's a lot, it's a diagnosis of exclusion, and there's a lot of things that criteria you have to fulfill. This child that I'm showing here has a peaked pupil towards the limbal wound. So in summary, mucogenic glaucoma is a super rare case of open-angle glaucoma. Iris cysts could or could not be related to trauma, and maybe there's a role in amniocentesis, but it will always be pretty hard to prove. Here's the quiz. All right. 10 responses. I think that's pretty good. Oh, yay. Okay. I'm glad nobody picked D. So, all right. So that's our objectives. Here's the abstract and my references. Thank you so much.